All right, everyone. So as Laura said, I am Dr. Taya Johnson. I'm going to be talking with you all. This is the Clinical Pearl series that I have been doing over the last few months. And this specific talk today is on treating depression and anxiety in children and adolescents. So today's goals and objectives, at the end of this presentation, you all should feel that you have increased information to recognize the presentation of depressive and anxiety symptoms in children and adolescents. Someone is not muted. Okay.
You should be good to go now, Dr. Johnson.
Okay. Thank you. Recognize the presentation of depressive and anxiety symptoms in children and adolescents, provide examples of how to screen and assess for depression and anxiety in children and adolescents, and then describe the different treatment options to consider when treating children and adolescents with depression and anxiety. So let's start with major depressive disorder. So for the clinical presentation of major depressive disorder, going through medical school, I learned the mnemonic of Siggy caps. Some people use a different mnemonic, but that was the mnemonic that we used in my medical school training. And that would just give you the symptoms of depression to help you remember the symptoms of depression. And so going through that mnemonic, S stands for sleep disturbances, so either having too much or too little sleep. The I stands for interest decreased or anhedonia, no longer finding, pleasure in things that used to make that the person used to find pleasurable. The G stands for guilt or worthlessness. The E stands for energy decreased. The C stands for concentration issues. The A stands for appetite, weight changes, increase, and either an increase or a decrease in appetite or weight. The P stands for psychomotor retardation or agitation. And then the S stands for suicidal ideation. Now, these symptoms, in order to be diagnosed with major depressive disorder, you need 5 or more of these symptoms to be present for at least 2 weeks, and one of the symptoms must be a depressed mood or the loss of interest or pleasure. Um, if neither one of those is if neither one of those are one of the symptoms, then you're probably not dealing with depression at this point. As a clinical pearl for this, depression in children and adolescents presents much different from depression in adults. And so in children and adolescents, we typically see a lot more mood lability, irritability, low frustration tolerance, somatic complaints, and or social withdrawal instead of them describing feelings of depression. So children and adolescents are much less melancholy, so report less melancholic symptoms and delusions than adults. So this is very important because when you have a child or adolescent presenting with irritability, that does not necessarily mean that you need to do a second generation antipsychotic to treat that irritability. I think sometimes we get kind of stuck in algorithms where it's, if someone comes in complaining of their child having a lot of irritability, then we say, oh, either that irritability is, maybe ADHD or that irritability is something that can be treated with a second generation antipsychotic such as Abilify or Risperdal, and this patient is never assessed for screened or assessed for depression. And so we have to remember that in children and adolescents, that can be a prominent symptom, and it's not necessarily that they have bipolar disorder either, because that can also get misdiagnosed as well. But we need to, if someone comes in and say with the complaints that their child is more irritable lately, we need to do a more thorough evaluation into what that irritability is about and make sure that it's not secondary to depression, or make sure we do not ignore that depression could be a cause of that irritability versus any other diagnosis, like I said, such as ADHD or bipolar disorder or whatever other diagnosis people like to diagnosed when someone presents with irritability. So just remember that irritability is a sign of depression in children and adolescents. And so when it comes to screening and assessing for depression, the guidelines state that all children and adolescents should be screened for depressive symptoms when they come to your office. So just doing a quick screening tool, such as the PHQ-9 or PHQ-2 even, just to kind of see if they even have symptoms of depression. And then if the screen is positive, then you want to thoroughly evaluate further. You need to also evaluate for the presence of thoughts to harm self or others, because suicide is now the second leading cause of death among those ages 10 to 24, according to the CDC. And so that's something that we need to evaluate for when we're screening for depression. We also make sure that we screen and evaluate for thoughts to hurt self or others. And then we also need to assess for the presence of psychosocial stressors, which can precipitate depressive symptoms. So we need to look for things, changes in environment, changes within the home, changes at school. Is there any bullying going on? Is there family divorce? Is there a death in the family? Any kind of changes, we need to assess for those psychosocial stressors as well. Now, we should consider depression if the symptoms are present most of the time, they interfere with the child's psychosocial functioning, and they are above and beyond what is expected for the child's age and level of development. So if if someone comes in and they say the kid gets sad some of the time, but it's not majority of the time, that we probably don't need to worry about depression. If we don't notice any interference with psychosocial functioning, we might not need to worry about depression. And then if it's just above and beyond what is expected for a child of that development, we might not need to consider for depression. Now, a clinical pearl with this is that tools such as the PHQ-9 are only screening tools. So that means they are not diagnostic. So just because someone comes to you and they have an elevated PHQ-9 or any other depressive screening tool that you may use, that does not mean that they have a diagnosis of depression. That just means they are endorsing a lot of symptoms consistent with depression, and you need to further evaluate to determine if it is the reason why they are endorsing a lot of these symptoms on the screener. Is it because of actual depression or not? These tools can be utilized, though, to follow treatment outcomes. So if you give someone a PHQ-9 and it's very elevated, and then you do your further evaluation and you believe that they meet criteria for depression, then you can start treatment. And then as you continue with treatment, you can use the PHQ-9 to follow improvements in treatment or even worsening in symptoms over time at follow-up visits. So it does help, but you just cannot use it as a diagnostic tool. And then another clinical pearl is that do not only screen for depressive symptoms, but also make sure, like I said above, that you assess for psychosocial stressors, which may be present and can contribute to depressive symptoms. Because a lot of times there may be several psychosocial stressors that are at play when a patient is coming to you for symptoms of depression, and you need to make sure that you are aware of those, because those psychosocial stressors can impact how well a patient improves or does not improve if those psychosocial stressors are still present even when you start treatment with them. So that's why it's very, very important to make sure you assess for those psychosocial stressors. Now, when it comes to treatment and we're deciding between meds versus no meds, when do we decide that medicines are needed? When do we not decide? When do we say no, we can do without medications? So it basically it depends on the severity of the symptoms. In the mild cases, you can utilize just psychotherapy only. So just making sure that they have education, support, and case management to assist with psychosocial stressors that may be impacting their their mood. And then just observe the response after 4 to 6 weeks of psychotherapy only, and kind of see how things are going. Do you see a slight improvement? Do you see things worsening, or things staying the same? Just kind of monitor them over the 4 to 6 week time period and see what is happening. Now, when it comes to moderate to severe cases of depressive symptoms, you probably need to do psychotherapy and or medications. So with moderate cases, they may respond to just cognitive behavioral therapy or interpersonal therapy alone. Um, or you might have to add medications along with the moderate severity. But in severe cases, generally you want medications and a combination approach, medications and psychotherapy, because that's going to be the best bang for your buck as far as improvement in symptoms when someone has severe depression. Psychotherapy enough may not get it, and research shows the medication alone won't get it either. So you might have to include um, you might have to do the combination approach for that. Now, as far as clinical pro with this, a lot of patients say that they have been in therapy and that they are in therapy, but when they tell you that, be sure to ask about their participations with therapy, because oftentimes you will hear a patient say, "Oh, I've done therapy before," or "I'm doing therapy right now and it's not working, it's not doing anything." And then when you probe them, you find out that they have the wrong expectation for therapy. Usually, patients believe that they can just go to a session or go to therapy sessions, and that is all is required for them, and then they can go home and supposedly life is supposed to be different. And I have to explain to patients that they must utilize what they learn in therapy outside of therapy in real life environments if they want to see significant improvement in symptoms. So it's not just, oh, you go sit in the office and talk and then you go home and everything is better. No, you got to utilize the things that you are talking about and learning about in therapy and apply those in real life when you get outside of the office. Now, sometimes patients don't like that because that requires more work. So you will hear a lot of times that patients will say they don't like therapy, they don't want therapy, they don't need therapy, and that's because they don't want to do the work. But I explain to them all the time, medications alone are not going to help with whatever environment that you're living in or whatever environment you go to when you walk out of this office. So the therapy is what helps you with um, being able to learn strategies and coping skills to handle things as they come up in real life that medications cannot address. Now, when it comes to treatment with medications, we have basically a guideline on how we approach this with um, with our patients. And so, the first line medication for depression in children and adolescents are the SSRI antidepressants, so the selective serotonin reuptake inhibitors, which include fluoxetine, sertraline, citalopram, paroxetine, and fluvoxamine. Now, paroxetine and fluvoxamine, I generally don't use either of those for depression. I'll go into the reason why I don't use paroxetine a little bit later. Fluvoxamine is FDA approved for OCD, so I typically don't utilize that unless I'm dealing with a patient with OCD. But it is an SSRI, so for completion, I listed it here under the list of SSRIs, but it's not one that I utilize. The most common side effects with the SSRI includes GI symptoms, sleep changes, increased sweating, headaches, restlessness, change in appetite, and sexual dysfunction. These side effects are usually short-lived and dose-dependent. So what I tell patients is you might have these side effects for, a week or so, but after that they should go away. And then, if it's on a higher dose and the symptoms are the side effects are too distressing and they don't go away, then we may have to lower the dose or find another medication if the patient is not functioning well with the side effects at higher doses. Now, the second or third line for the treatment of depression in children and adolescents are the SNRIs, or the serotonin norepinephrine reuptake inhibitor. Again, these are second or third line, and those include venlafaxine, desvenlafaxine, and duloxetine. The most common side effect that we worry about with those is increased blood pressure and tachycardia because of the norepinephrine component of the medication. Um, Typically, if I'm going to use any of these in children or adolescents, it's typically either going to be venlafaxine or duloxetine. I don't use too much desvenlafaxine in this patient population. Not saying that it doesn't work. I just never utilized it for children or adolescents. Other antidepressants, which are second or third line again, are bupropion, which is a norepinephrine dopamine reuptake inhibitor. This one you can utilize and could be more beneficial in a child or adolescent who has comorbid depression and ADHD, since bupropion is approved to be utilized as an ADHD treatment. So if you have someone that you don't want to do multiple medications on this, and they have both depression and ADHD, this may be a treatment option that you choose for them. You might use this one first line in a patient with comorbid depression and ADHD instead of using the SSRI if you're trying to kill two birds with one stone. Um, and then mirtazapine, which is a serotonin adrenergic receptor blocker. This is again is a second or third line antidepressant. Most common side effects are increased appetite and weight gain and somnolence. So I would utilize mirtazapine in someone, if they are having significant sleep issues that do not improve with treating the depression. Or they've had side effects to the SSRIs and it's just not working, but they have a lot of sleep issues, or a lot of poor appetite symptoms from their depression, then as a second or third line I might consider using mirtazapine in that patient. And then we have the tricyclic antidepressants, or the TCAs, and those are way, way, way down the line as far as utilizing them. And it's not because they are not effective and don't work. They work very, very well. But the concern for using TCAs in children and adolescents is that there may be an impulsive fatal overdose in this age group. And so that's why I usually avoid it in children and adolescents unless I absolutely have no other option. But because they do work, like they work and they work well, but it's that fear of fatal overdose with the cardiac implications of that a teenager may, or a child may, impulsively do because they got into an argument with their parent, and then they end up overdosing on one of the tricyclics, and then they end up accidentally killing themselves because they were just impulsive in the moment. So that's why I do not typically utilize TCAs in this age group. Now, when it comes to medications and if things are improving or not improving, we have to take in account the time frame. It takes 4 to 6 weeks of consistently taking the antidepressants before one can assess for a change in symptoms. And this time frame is applicable for each dose change. So what I say to patients is, I'm starting this medication today. You will not notice a difference probably for 4 to 6 weeks. What that means is that if you call me in 2 weeks and say, Dr. Johnson, my medicine is not working, I'm going to say, remember we had this conversation that it takes about 4 to 6 weeks of taking the medicine every single day before we can know if it's helping you or not. So we're just at 2 weeks, so we have to give it more time. And that usually helps with their expectations of what the medicine does, or what they expect the medicine to do and in what time frame. Because sometimes patients are like, well, I only take it when I feel sad, and I have to explain to them, no, this is not a medicine that you take like Tylenol or ibuprofen, where if you have a headache you just take it, but if you don't have a headache you don't take it. No, this is a medication that you must take every single day, no matter how you feel, because the medicine has to build up in your system. And so, and then I explain that to them, that this is what occurs at every single dose change. So if we're taking sertraline 25 milligrams for 4 to 6 weeks, we see a little bit improvement in mood, but not a whole lot. We're going to go to 50 milligrams. Now at the 50 milligram dose, we have to give it that 4 to 6 weeks again to make sure that we give it the time frame that it needs to reach steady state in the body and become effective. So more medication clinical pearls. In general, start with the SSRIs. When treating children and adolescents, they have the more tolerable side effect profile. Start low and go slow with all of the antidepressants. So basically start with the low dose first to decrease the risk of side effects, and then slowly increase the dose over time. Because sometimes I have seen patients that were maybe started on too high of a dose of an antidepressant, and then they complained of side effects because of starting that antidepressant at a higher dose, and then they say, well, I don't want to take it anymore. it didn't work for me. And it's like, well, you actually truly didn't have a adequate trial of the medicine. You just were started on too high of a dose. You probably should have been started lower dose and slowly increased. And so to improve the buy-in on some patients with taking the antidepressant, starting low and going slow with increasing the dose is what I recommend and is what I actually do. Now, when a patient says that they don't have any improvement in their symptoms after 4 to 6 weeks, make sure to ask if they are taking their medication every day. Because if they miss a dose, depending on the half-life of the antidepressant, missing just one dose can disrupt the steady state of the medicine. And so we need to make sure they're taking the medicine every day and not taking it, only when they feel sad or whatever. Now, when prescribing the SSRIs, fluoxetine has the longest half-life of the SSRI antidepressants, and paroxetine has the shortest half-life of the antidepressants. And so because of this, when I was saying earlier that I stay away from paroxetine, this is why I stay away from paroxetine with children and adolescents, because the withdrawal effects from missing one dose of paroxetine are very uncomfortable, can increase the risk of, suicidal ideations and, make a patient not want to take that medicine ever again. And so I just stay away from paroxetine unless the only time I prescribe it is if somebody comes to me and that they are, very adherent and compliant with their medications and it works for them and they make sure to take and don't miss a dose, then I will continue with that. But otherwise, most people miss their doses of their medications, and this is just not a good one to utilize in children and adolescents because more than likely they're going to miss a dose. But with fluoxetine, a patient can miss a dose and it wouldn't change the steady state of the medication in the body because the medication has such a long half-life in the body, the fluoxetine does. So I like using fluoxetine in children and adolescents because it's highly likely that they will miss a dose at some point, especially with adolescents. And so again, that prevents them from experiencing that withdrawal effects that they would experience if they took paroxetine. And so that's why I like to utilize fluoxetine in those situations. Now, as far as treatment after remission of symptoms, you should continue treatment with antidepressants for at least 6 to 12 months after remission of symptoms, possibly over a year if the patient had severe depression prior to the medication. But at that point, after the 6 to 12 months of remission of symptoms, no changes in dose for that 6 to 12 month period, you can start to try to taper the antidepressant down and monitor for the recurrence of symptoms with each dose decrease. And you may be able to get the patient off medications. So when they come to you and say, "Doctor, how long will I be on this medication?" I typically tell them, "I'm not sure, but what I typically try is we get to a point where your symptoms have resolved for 6 to 12 months. And then after that 6 to 12 month period, we can discuss tapering down and trying to see if you can get off the medication." Now, when it comes to the black box warning for the antidepressants, all of the SSRIs and all of the antidepressants have a black box warning for suicidal thinking and behavior, but not actual suicide attempts through age 24 years. So I want to make sure that you all understand that it's just for suicidal thinking and behavior, but not actual attempts. And this came from a study where it said that the percentage of suicidal ideation across all antidepressants is 1% for youth treated with an antidepressant compared to 0.2% for youth treated with placebo. But the data shows that you would need to treat 143 patients before you got one harm with suicidal thoughts or behaviors versus you need to treat 3 patients in order to see improvement in depression. So basically, the risk benefit is greater benefit to try and treat the depression with the antidepressant and not withhold treatment with an antidepressant because of fear of the suicidal ideation. So basically, despite the low apparent risk, you still just closely monitor for suicidality, which is recommended by the FDA, especially in the first months of the treatment and following dose adjustments. So so you monitor for it, but don't withhold prescribing an antidepressant because of your fear of the patient developing suicidal thoughts or behaviors secondary to the SSRI use. And then we typically, as a CPAN provider, I get calls a lot about the role for pharmacogenetics testing, and this randomized controlled trial was published in the Journal of the American Academy of Child and Adolescent Psychiatry in June of this year, and this study did not find any differences between treatment as usual, which treatment as usual is basically what I've been explaining thus far in this presentation, which is utilizing the SSRIs first and then, going to other antidepressants if needed. There was no differences between the treatment as usual arm versus the pharmacogenetics testing arm regarding symptom improvement, side effect burden, or satisfaction. So pharmacogenetics guided treatment did not show an improved outcomes compared to treatment as usual in children in in adolescents with depression. So the clinical pearl for this is at this time, there is no clear role for pharmacogenetics testing in medication selection. So there is no need to get these results prior to choosing which medication to try in a patient. That's a use of resources that's just not necessary, and that's proven by this study. We just need to continue to do what we've been doing, which is starting with the evidence-based treatment that we had prior to these pharmacogenetics testing taking place, which is starting with the SSRIs and then going from there. So I wanted to make sure to add that because that is new research that came out in June of this year. And also the FDA has spoken on this last year or the year before last. It might have been 2019. They also spoke on utilizing these tests as a way to quote unquote decide which medication is the best for patients, and the FDA recommended against doing that as well. So this is just going along with what we've already kind of had an ideal about, that utilizing pharmacogenetics testing is just not necessary as far as telling you which medications or how to proceed in treating a patient with depression. And so now we're going to switch gears to anxiety disorders. Now, I'll put this graphic in the presentation because I just really like how it shows that anxiety can show up in many, many different ways. And so, you might have difficulty falling asleep. You might have some irritability or get angry. There might be some defiance because of anxiety. There might be, avoiding activities, so not wanting to go to school. You can have, physical complaints, headaches, stomach aches because of anxiety. You can have issues with focus and attention, crying and difficulty managing your emotions, constant worry. There's just so many different ways that anxiety can present itself. And so when you have someone presenting to you in your office for different, mental health complaints, we always need to make sure that we screen for anxiety because it can present in many different ways. So, clinical presentation. So with anxiety, it may present with fear or worry that the patient does not recognize as irrational. There may be some common complaints of somatic symptoms. So like I said, headaches or stomach aches. There could be crying, irritability, and anger outbursts, which can be misunderstood as defiance when actually the child is just trying to express their feelings of anxiety, or they're trying to avoid whatever stimulus is causing their anxiety. And so the clinical pearl for this is that fear and worry is normal and common throughout the different stages of childhood. The issue becomes when it is determining whether it is developmentally appropriate anxiety or anxiety which is impairing the child's functioning. So you need to distinguish between the two, because it could be completely normal that this child is experiencing anxiety in certain situations, but that anxiety is not impairing their functioning, versus a child who has anxiety which is not normal developmentally and it's impairing their ability to function at school or with friends or whatever. And then the context of in which the anxiety symptoms arise is very, very important for diagnosis. So we're going to go through the different diagnoses of anxiety, and you'll see that paying attention to the context of when the anxiety occurs is what's very, very important, a very important detail for the diagnosis. So with separation anxiety, There is significant fear and distress when separating from home or from their parent or caregivers. The child may worry about the parent's safety or health when they're separated. They may have trouble sleeping alone. They may exhibit school refusal, so they don't want to go to school because they are scared of what will happen to their parents or caregivers when they are at school. And they may have somatic complaints. And this will be developmentally inappropriate. So when kids are about 9 months old, separation anxiety is normal. Once you get past a year or so old, that should no longer be a major complaint. So if you have a 6-year-old who cannot leave their parent's side, that's developmentally inappropriate, and we need to, get engage them in treatment to help with that, address that. Then there are specific phobias where there's a fear of a particular object or situation that is avoided or endured with extreme distress or impairment that is related to that particular stimulus. And a person can have more than one specific phobia. So this would be a fear of heights, a fear of bugs, a fear of, snakes, spiders, anything that you can think of. Somebody can have an extreme fear about that one stimulus or several of those stimuli, and that would be a specific phobia if those symptoms of distress and impairment only occur when that stimulus is present. Then we can have generalized anxiety disorder, which is a chronic excessive worry in different areas, and the patient has trouble controlling the worry. This worry is present majority of the time, and the worries are not limited to a specific object or situation. So this is the person who, when you ask them what worries them, they say everything, and then they go through a list of, different things that they can think of at that time. Um, then we have social phobia, which is anxiety in one or more social situations or performance situations. Um, this these will be patients who fear social scrutiny and doing something embarrassing in front of others. And then they may have difficulty answering questions in class, reading out loud, initiating conversations, and attending social situations. We can also have selective mutism, which is a consistent failure to speak in specific social situations where speaking is the expected. Um, where speaking is expected despite speaking in other situations. So this is when you have a child who may only talk to mom or dad at home, but when they go to the restaurant, they don't speak at all. Like, they won't order their own food, or when they come to see you at the office, they don't speak to you in the office. They only talk to their parents. So it's in specific situations where they don't talk. And then we have agoraphobia, which is excessive fear or worry about being in a situation in which the individual may not be able to escape. And agoraphobia can occur with or without panic disorder. And then we have panic disorder, which is recurrent, unexpected episodes of intense fear. There may be fear of recurrent panic attacks, and a patient may develop an avoidance of a certain situation or setting where the panic attacks previously have happened before. 4 or more of the following somatic symptoms must occur during a panic attack, and that those are listed here: palpitations, sweating, trembling, shaking, difficulty breathing, feeling of choking, chest pain, discomfort, nausea, abdominal issues, dizziness, lightheadedness, numbness, tingling, feel of losing control, fear of dying. So at least 4 or more of these must occur when during a panic attack in order for a person to be diagnosed with panic disorder. Now, screening and assessment for anxiety disorders. Screening is typically recommended during the first mental health assessment visit because there is a high prevalence of anxiety disorders among children and adolescents. So while for depression, we screen for depression regardless of if, we just screen for depression at well child visits, well child techs. We don't necessarily have to screen for anxiety unless a patient comes in and complains about some mental health issue. So whether it's mom or dad saying, there's irritability, too much irritability, or they're coming in complaining of depression. You also want to screen for anxiety in those situations. So when someone comes in for their first mental health complaint, you want to also make sure you screen for anxiety. Even if they think that it's something else going on, you need to screen for anxiety in those appointment settings, because early identification can facilitate early intervention. And you can utilize several different screening tools to evaluate for anxiety. So the SCARED is the one that I like using a lot. That is the screen for child anxiety related emotional disorders. You can use the GAD-7. You can use the SCAS, which is the Spence Children's Anxiety Scale. And you can use the preschool anxiety scale, the parent version. All of those are listed online, available for free. If you are a part of CPAN and you're enrolled in CPAN with us, we provide in our welcome packet the SCARED and the GAD-7 for you all to utilize to help screen for anxiety. So the clinical pearls with anxiety screening and assessment. Again, the tools that I named are only for screening and not diagnostic. So once you have a patient who is positive on these screening tools, then you need to conduct a thorough evaluation to further assess the symptoms, to get and also to figure out the diagnosis. Now, a diagnostic evaluation will identify the following. You will identify symptoms. You will identify syndromal symptom combinations, symptom frequency, severity, onset, duration, the degree of associated distress and functional impairment, developmental deviations, and physical signs. And then you also need to, within that evaluation, you need to make sure that you rule out several other diagnoses, because they have symptoms. Several psychiatric conditions have symptoms that mimic anxiety as well, such as ADHD, autistic spectrum disorders, depression, and learning disabilities. So rule out those conditions, or they can be co-occurring with the anxiety. So it's not that it doesn't always have to be either or, it can be both and in certain situations, but you need to make sure that you evaluate for them and rule them out if they are, make sure you know if they are or are not present. Now, again, the conversation, meds versus no meds. What should we do? And it's basically something very, very similar to treating depression. It depends on the severity of the symptoms. So in mild cases, you start with psychotherapy like we talked about with depression. For moderate to severe cases, you may want to do psychotherapy with or without medication, just kind of depending on how severe the symptoms are. Most of the time, if it's very severe and the child can barely function, I'm definitely going to use medications along with therapy. Now, why would you there are several reasons for combining medications with therapy. You can get an acute reduction in moderately to severe cases, acute reduction in symptoms in moderate to severe cases. You may have a co-occurring disorder which requires medication treatment, and that's why you want to utilize medications with therapy. And then you may have a patient may have a partial response to therapy alone, and so that may be a reason that you want to combine medications with therapy. And pretty much research shows us that medication and therapy together is what is best. And so the American Academy of Child and Adolescent Psychiatry recommends combination therapy, so CBT, cognitive behavioral therapy, and an antidepressant, SSRI, preferably over an SSRI or CBT alone, with patients ages 6 to 18 that have social anxiety, generalized anxiety, separation anxiety, specific phobia, or panic disorder. Now, the clinical pearl for this is you want to monitor for improvement in functional impairment and not just anxiety symptom reduction with treatment. And the reason for that is anxiety is present. Everybody experiences anxiety. We're never going to make anxiety go away 100%. And so we just need to make sure that the child is functioning better and focus on that more so than is the anxiety decreasing, because anxiety is still going to be present. And then there will be a point, a plateau, where you will not be able to get the anxiety to decrease any further. And that doesn't mean that the treatment is not working. It's, we need to, like I said, evaluate, is the functional impairment improving more so than is the anxiety completely going away. Now, cognitive behavioral therapy, or CBT, shows the most evidence for treatment of anxiety disorders. And CBT includes psychoeducation about the illness, um, and CBT with parent and child, just to understand what the illness is and what CBT is. Um, then it includes somatic symptom management skills training, so how to deal with the physical symptoms that they experience when they're having anxiety. And then cognitive restructuring, so changing their thoughts about what is happening. And then exposure methods, so exposing them to whatever stimulus triggers their anxiety, and them learning how to deal with and manage their anxiety symptoms when they are exposed to differing levels of that stimulus that provokes their anxiety. Relapse prevention plans, um, and then they may need to make modifications for a specific diagnosis. So you might do something specifically for a specific phobia that you would not do with generalized anxiety disorder. The American Academy of Child and Adolescent Psychiatry recommends that CBT be offered to patients 6 to 18 with social anxiety, generalized anxiety, separation anxiety, specific phobia, or panic disorder. Um, Other forms of therapy may be utilized for anxiety, but they're just not as extensively studied in anxious children and adolescents. But that's not to say that they cannot be helpful as well. It's just that CBT has the most evidence, and that's the most research that we have. Now, regarding medication clinical pearls, so when we are talking about medications, we need to consider medicines when the anxiety disorder symptoms are moderate to severe. um, the impairment, the functional impairment of their anxiety makes participation in therapy very difficult, or there is a partial response to the therapy. So that's when you should consider medications. And the SSRIs are, again, like with depression, are the first line, should be considered first when treating children and adolescents with anxiety disorders. They are the medication of choice for anxiety disorders in children. The American Academy of Child and Adolescent Psychiatry recommends offering SSRIs to patients ages 6 to 18 with social anxiety, generalized anxiety, separation anxiety, or panic disorder. Again, like with the antidepressants, with treating depression, we should start low and go slow with all the antidepressants in treating anxiety. We start with a low dose first to decrease the risk of side effects, and then we slowly increase that dose over time. Um, Again, if patients say that they don't have any improvement in symptoms, just as we said with depression, we need to make sure that we ask about, after 4 to 6 weeks of them taking the medication, ask about adherence and taking their medication every day. Again, depending on the half-life of the antidepressant that they are taking, just missing one dose could disrupt the steady state of the medication. So, like, that's the same as with treating depression. And then consider a medication-free trial when the patient has remained symptom-free for at least a year, and then continuously monitor for recurrence of symptoms. So, like with depression, after about 12 months, start tapering off the antidepressant and kind of see if you can get to either a lower dose of the medication or no medication, and then just continue to monitor if symptoms recur. Um, Other antidepressants should be tried if a patient has failed treatment with at least 2 SSRIs, but there is minimal evidence to discuss the efficacy of other antidepressants in children and adolescents. So you can try it, but that doesn't, we just don't have the evidence-based medicine to show the efficacy of other antidepressants when treating anxiety in children and adolescents. Now, the benzodiazepines have not been shown to have efficacy in controlled trials for anxiety disorders in children and adolescents. They can be cautiously used in the short term to achieve rapid reduction in anxiety symptoms while waiting for the antidepressant to take effect, but they should not be used in the long term. Just because of the risk of benzodiazepines with, developing tolerance, and then the risk of abuse, not even just with the patient abusing the benzodiazepines, but anyone in the household abusing them. They have street value and things like that. And then the long-term effects of the benzodiazepines on memory and increased risk of developing Alzheimer's later on in life. I just stay away from the benzodiazepines if possible. Buspirone is a well-tolerated medication that can be used for generalized anxiety, but there are no controlled trials for children and adolescents with regarding the treatment of buspirone. But you can safely use 5 to 30 milligrams twice a day in adolescents, and then 5 to 7.5 milligrams twice a day in children. The most common side effects with buspirone include headaches, lightheadedness, and then dyspepsia. And these are my resources, and I will leave it for any questions now.
Thank you very much, Dr. Johnson. Looks like we started having some questions in there. The first question, do you want to read the questions yourself, or would you like me to read them to you? I'm not sure what your screen is looking like.
I just got out of the PowerPoint, so I'm just now seeing the chat.
Let me read it so that those who are on from just their phone are able to hear the question.
Okay.
So question comes, is there any evidence-based support for interventions outside of psychotherapy, CBT, and medication? For example, sleep recommendations, diet changes, or other non-traditional treatments. Are there any of these interventions that a parent may report that a PCP should counsel against? And it doesn't state specifically depression or anxiety, so it's a general question.
So, that's a good question. And in general, anything that we as providers, medical providers, talk about for general well-being is going to be effective. So definitely sleep recommendations. If you have poor sleep hygiene, you are not going to be, your mood is going to be impacted by poor sleep. Your anxiety is going to be impacted by poor sleep. Diet changes as well. If you constantly eat, junk food all the time, that's going to impact your mood. So, exercise. If you are mostly sedentary and not engaging in exercise, that is going to impact your mood. So yes, all of those things are with general wellness and support, are in support of utilizing in the context of therapy and medication as well. So we definitely don't neglect those discussions with our patients as well. Now, the one intervention that I would tell PCPs to counsel parents against would be CBD, because that's the new craze right now. Everybody wants CBD oil for this and CBD gummies for that, and they think that it cures everything. And that's just not the case. The data does not show that it is beneficial or harmful in treating depression, anxiety, sleep, all these different things that people use it for. But the other thing that I have found in my research when looking into the CBD oils is that that I can usually get parents to kind of buy in on is that their research has looked into the several different manufacturers of CBD oil that claim to be 100% CBD and no THC component. And the research has shown that none of the manufacturers CBD oil that they examined in the study were 100% CBD. They all had some component of THC, which we as providers know the THC component of marijuana is what is the psychoactive component. That's what leads to psychosis, and that's what causes issues with brain development. And so what I explained to parents is your child's brain is still developing. If we introduce this CBD oil, which also has some THC component in it, we don't know what the effects on your child's developing brain this will have. And so therefore, I do not recommend utilizing CBD oil. Usually when I explain it in that way, the parents buy in on it and will stay away from it. But, some still do what they want to do. But that would be the main intervention that I counsel against is CBD oil or CBD product, period.
Thank you, Dr. Johnson. Other questions? And if you'd like to ask your question directly, you can certainly unmute yourself.
Yes, ma'am. This is Amy. I've heard, I've seen some kids that have gotten started on hydroxyzine for the anxiety. Can you comment on the use of that?
Yes, so I utilize outside. So what I'm presenting in this talk today is based on the guidelines from the American Academy of Child and Adolescent Psychiatry. But there are some interventions or medications that I utilize that were not in those guidelines. Hydroxyzine is one of those that I utilize as PRN usage for anxiety. You know, in the moment when anxiety is elevated and they need to kind of calm down and bring that anxiety level to something that's more manageable, I would utilize hydroxyzine in much the same way I would utilize propranolol in that fashion as well, especially with, anxiety is a heightened level of adrenaline. The propranolol is a beta blocker, so it, prevents the physical reactions to anxiety. And so I will utilize that as a PRN medication as well. So it's appropriate to utilize those. The main thing with the hydroxyzine is that, it can cause tiredness because of it being a antihistamine. And so, if it's making them too sleepy to be able to continue on throughout their day, then that might not be something that we want to utilize as a PRN medication. But if they find it helpful and they are still able to function, yeah, I utilize hydroxyzine quite a bit as a PRN use, for PRN use.
Other questions? Great question, Dr. Starr. I pasted the link for your for the evaluation. I'm going to show that screen here in just a minute where you can use the QR code, but do want to give the opportunity for others to ask questions if they'd like to. All right, for those of you who are not familiar with the Child Psychiatry Access Network, we are a network of 12 regional hubs in Texas that provide support to PCPs caring for children and adolescents. We actually serve PCPs that are caring for those as up to age 22 now. We've been able to expand that. Additional expansions are coming with new opportunities starting in 2022. So if you are already part of being registered with CPAN, watch for more information to come. If you are not part of CPAN, you're in this region, we would love to talk with you, provide you information about the services besides continuing education, but child psychiatry consultation right on the spot, such as Dr. Johnson is here. She and two of our other child psychiatrists are available 8 to 5 Monday through Friday to talk with you about cases, medication management, support with putting some plans together. We also can provide you assistance and support with identifying hard to find resources and referrals. And of course, our continuing education that happens several times monthly. I'm going to just pause for just a second, open up the floor and pull up our post presentation screen. Dr. Johnson, anything that you feel like you want to add here at the end? Anything about CPAN you think might be helpful for providers to know if they have not called us yet?
The only thing that I can think of is just that usually we have providers who are concerned about, interrupting our day or something regarding calling us for CPAN. And I just want, everyone to know that we are actually assigned specific shifts to be available for your calls during the hours of 8 to 5. So that's literally all we're supposed to do during that time is to answer your phone call. So you're not disrupting us when you're giving us a call, because we literally, it's not like you're pulling us out of clinic or in the middle of doing something else. That's our time to be set aside to be able to answer any phone calls. So I think that's one key thing to just reiterate.
Thanks, Dr. Johnson. I appreciate that. And no question is, too small or too large. We're here. We know that the data tells us that 3/4 of the kids that have mental health needs are being treated in primary care. And so part of our big focus is on educating primary care providers, because you're doing the hard work. There's just not enough child psychiatry out there, not enough mental health services out there. So allow us to be that partner with you, to be that curbside consult. We've provided some streamlined processes to make it easy for you. If you have been registered and you've not used us, so we encourage you to give us a call. Try us out. I think you'll be pleasantly surprised. If you have not used CPN services and you are a PCP in Texas and you aren't sure if you're registered, or you know you're not registered, we would love to be able to support you. Please contact us at our toll-free number, 888-901-2726. If you are in the Northeast region, you can go ahead and press 1 and then 3, and that gets you directly to our team here. If you just call that number and you're in a different region, you'll get the regional prompts and you can contact them. So question, any resources for teen pregnancy and mental health? So Mr. Zuniga, if you would unmute yourself and clarify your question for me a little bit, please.
Hi, so Physician Zuniga, one of the family practice obstetric physicians in Athens, Texas. Not a lot of mental health resources for us, and every now and then we have, I provide pregnancy care as well, and every now and then we have some patients that have depression, anxiety, and sometimes they're teenagers or pretty young. So,
sure.
So some, as far as medications that are safe to continue in a teenager that is pregnant, or things that we need to look at and things like that.
Okay, that's helpful. Yes, if you are in this region, if you give us a call, we can go ahead and support you with that information. It's very difficult to find resources for teens in general. And so that's part of what we do. We have a team of 2 therapists, that's Wiley and Elizabeth. And in the Northeast region here, we've created a huge database, and across the state, each regional hub has identified resources that can help you depending on where you are located. And depending on what the need is for that teen, as far as what kind of mental health services, we can help you identify that and provide those resources to you. If it's related to medication and such, we can certainly help with that as well. Our psychiatrists are willing to talk with you about what might be the best option based on the mental health need of that pregnant teen.
Awesome, thank you. And yeah, I've worked with them before. They have been amazing, helping us get some care for some of my kids here in Athens and getting us connected to therapy and specialists and everything. So it's been wonderful.
Yeah, Athens is a pretty tough area.
And I just wanted to add too, as far as which medications are safe to continue in pregnancy, I personally utilize the Massachusetts General Hospital Center for Women's Mental Health website, and they have a lot of resources there. If you go to resources and for providers, there's like a website that I utilize often, but they have LactMed on there. They have Mother to Baby. So there's a lot of resources there that you can go in and literally type in the name of the medicine, and then it will give you information on the safety within pregnancy. So that's where I go when I have those type of issues come up.
That's great. And then if you have looked at that website and you still have any other questions or would like to just confirm your thoughts on treatment, if it's related to medication management and such, please feel free and comfortable to give us a call. This is why we're here. The state's provided these resources, spent $104 million over the next biennium for children's mental health here in Texas, and CPAN is one of those 5 initiatives. So we're here for you, and we're not going anywhere, and let's go ahead and use the services so that we can keep having them. Any other questions? We are after the top of the hour, but we do want to provide you the opportunity. All right, it sounds like it's quiet on the other end. Dr. Johnson, thanks again. Your clinical pearls have been well received, and we look forward to providing this as a reoccurring, at least once a year, for those who have not been able to make that continuing ed. We will be presenting on the 7th of December. And if you are interested in attending that, please contact us at CPAN Info. I'll have that put in the chat, cpaninfo@uthct.edu. I'll send you the invitation. And then on the 15th of December, we do have our next CME on crisis intervention in the primary care. Our 2 therapists, Elizabeth Hooker and Wiley Martin, will be presenting that. Thanks and have a great day.